Welcome to Season 2 of UNprivate Parts. This podcast is a space where women can feel supported and understood as we have open, honest conversations about women's health and the uncomfortable subjects we all want answers to. In this season, we will explore the complex realities of breast and gynecologic cancer journeys, breaking them down with empathy and expertise. From hearing the words, "you have cancer," to making decisions, undergoing treatments, navigating survivorship, and seeking support, we will cover it all. Nothing is off limits, and no topic is too uncomfortable to discuss here. This is UNprivate Parts.
Hi, I'm Lauren Smith, the Manager of Business Development here at Women's Hospital and the host of UNprivate Parts podcast. Breast cancer is not one single disease. It's made up of several different types, each with its own characteristics, risks, and treatment approaches. In this episode, we're breaking down what breast cancer really is, the different types women should be aware of, and how factors like genetics, age, and breast density play a role in the risk. We'll also talk about the importance of screening, when to start mammograms, and how early detection can make all the difference. Joining us to guide this conversation is Dr. Lindsey Fauveau, one of our breast surgical oncologists here at Women's Hospital. Thank you for being here. Let's start from the very beginning. What is breast cancer?
So breast cancer is, as it sounds, ultimately there is a cancer cell, which is foreign to you, that has hijacked a natural cell in your body for its own purpose. And so your immune system works 24 hours, day in, day out, to identify these erroneous cells in our body that shouldn't belong here. And the majority of the time they do a good job at protecting you, but occasionally things do happen and slip through the cracks, and that's whenever you get any type of cancer, but in particular a breast cancer.
And what are the different types of breast cancer? Or is there a specific number, or is it kind of as it grows?
Well, so cancer in general is labeled based off of the cell origin. So our breasts are made up of three structures. So you have the ducts that are the tube-like structures that bring the milk from the lobules to the nipple for breastfeeding. You have the lobules, which are the grape-like clusters that make the milk. And then the predominant form of your breast is fat. So cancers ultimately form from ducts, from lobules, but you also can have cancer not only that's from those structures, but they can be in different parts of your body as well. You can have breast cancers that pop up absent of having something in your breast, which is very rare. It's called an occult breast cancer, where it starts off in your armpit or somewhere else in your body with nothing present in your breast. So really, any type of cancer is labeled based off of what cell origin, like what does it look like to the pathologist under the microscope. But if it comes from those structures within the breast, then it's technically breast cancer.
So how does it typically develop and spread?
So when you look at a mammogram or any imaging that detects an abnormality that leads you to a breast cancer diagnosis, what happens is that when we typically will see a rounded mass, and it's not a perfect science, but those typically are going to end up being ductal cancers. They come from a rounded tubular-like structure. Common things being common, they form a rounded mass. But that's not always true. Ultimately, when we see a little bit more of a vague abnormality on imaging, our spidey senses in radiology and in breast surgery end up leaning a little bit more toward the lobular pathology. They don't grow in a spherical manner like ductal cancers do because they come from the lobules. So they grow in what's called an interstitial growth pattern, so almost like spaghetti or hair tendrils through the tissues. And so sometimes those are harder to identify on imaging. And oftentimes in the radiologic workup, when you have a diagnosis, sometimes an MRI will show that it's much bigger than it shows on a mammogram or an ultrasound. So it's not as if, I think everybody has this magical picture of, I'm gonna feel a spherical mass in my breast, but it's not that simple. And so you have to have just breast self-awareness to know that something feels off, and that's good enough.
And what is the difference between invasive and non-invasive breast cancer?
So non-invasive breast cancer is breast cancer. It's just confined within the ducts of the breast. It has a lot of different names. You can call it non-invasive breast cancer, which I like because it does not diminish the fact that it is breast cancer. The common terminology that you'll hear from patients is DCIS. That's an acronym for ductal carcinoma in situ. The in situ portion means that it hasn't broken through the basement membrane of the ducts, and because it hasn't left the ducts, it doesn't have access to the lymphatics of the breast, and that is how it travels outside the breast. So it's non-invasive because it does not have the access to the lymphatics. Now, there are some structural situations where that 1% to 2% chance that it could be in your lymph nodes predominantly is in non-invasive breast cancers that are very close to the armpit. So if it's high up in the breast, in the upper outer quadrant, then you can have potential for it to spread, but it's typically not. 98% of the time, non-invasive breast cancer is not in your lymph nodes and not outside your breast.
Whew. So does that typically mean when it's contained, surgery will just take care of it?
Yes. So
Okay.
that predominantly is a surgically managed disease. So when you talk about non-invasive breast cancer, actually the development of that in particular has been pretty miraculous. You know, when you think of the history of breast surgery in the 60s and 70s, back whenever we thought that surgery cured this disease, patients indiscriminately got what's called a modified radical mastectomy. And they would initially feel a mass, and then you would go see a surgeon, you would get your breast and all of your lymph nodes and a portion of your muscle removed. And what we ultimately found out is that that did not one size fit all. Some people did really well and had a great life with no recurrence of the breast cancer, but then some people did poorly. And then it led us to say, okay, well, can we save your breast? And then that snowballed into us really wanting to restore a sense of normalcy. And it led us to doing routine mammograms, which technically started in the late 80s, early 90s. So with the advent of new imaging, when they did surgery prior to that, they would see that on the pathology, there would be invasive breast cancer, and then there'd be a smattering of non-invasive breast cancer with it. So they thought it lived together, and that we were seeing that evolution chart of what I described to my patients as like the apes all the way up to the caveman, but it was all in one snapshot. And what imaging allowed us to do was to isolate that initial portion. So they were able to see things earlier before you got to the time in your life where you felt a mass. And so they see it as calcifications or as sort of a shadow on your mammogram, enough so that the technology has brought us today to where now within that 1 in 8 women having breast cancer, 1 in 33 are non-invasive breast cancer because we caught it on mammography where it didn't even have the time to progress to invasive breast cancer. And that is why it's stage 0, because by the time we have those patients, 1, 2, 3, and 4 were already taken. So we kind of fit them in where they fit. And so historically, it is probably the best success that we've had as a joined union between the progression of the imaging, the technology, radiology, surgery. And we've given a lot of people a great prognosis by catching it to where they don't have invasive breast cancer and they're being treated for non-invasive breast cancer.
I did not realize mammograms started in the 80s.
Yeah, as a routine study, the study was predominantly with nurses in hospitals in New York State.
Wow.
And so the buy-in had to be within the medical community. Can you imagine it not being a routine thing where everybody did it and saying, I'm going to x-ray you,
right,
and you're going to have radiation, but it's going to help you? I mean, it's such a strange concept, but it does. It saves lives. And so the fact that those nurses were willing to join into a study and make sure that they, used their willpower to give us all a better prognosis is amazing.
Is that where the age 40 came into play because of that study? Or When should women begin?
Yeah,
Why
so
that age?
that's a little blurry. Mammograms do a great job in postmenopausal breasts. So remember those structures, the ducts, the lobules, the fat? When you're premenopausal, you're primed for breastfeeding, so you have more structural components of your breast and less fat. And so you're more apt to have a dense breast when you're younger. Whereas once you hit menopause, your body says, okay, well, I might not need these structures. I'm pretty sure I'm done with breastfeeding. And those start to involute and regress, and your breasts become more fatty replaced, which makes for a better mammogram. So mammograms were initially designed for postmenopausal breast. And so that's why the routine usage of them began at age 50 years before now. Oh. And we've progressed now to lower the usage of mammograms to 40 because we know that this isn't a disease isolated to postmenopausal women. So the conundrum current state is you're using a modality where it's ideal for postmenopausal breasts, but you're using now premenopausal patients. And so the progression in the technology that's compensated for that density is the use of 3D technology. So rather than doing a 2-view mammogram, you now have a little portion of your mammogram that does a 3D image, and that allows the radiologist to scroll through and has a good shot of them not saying that your breast density is something scary. So it reduces the callback rate for dense breast by 15%, which is good. We don't want to, tell people that there's something when there's not. But where also you compensate is that if you do your screening mammography and they need to call you back for additional images, whether that be additional mammogram or ultrasound, it can just be for dense breast tissue because it's not meant for a premenopausal breast, and we're having to compensate for that. So I find that a lot of people have a moment where they're terrified, and then they go have their additional imaging and they're fine. And they oftentimes wonder, well, why couldn't we just do all of this at the onset? But also, not everybody has to do that. So just because you have to make a second trip to radiology does not mean that you have a cancer diagnosis.
How does breast density impact imaging?
So that's a very, very good question. And I think that our radiologist would love to do an interview with you about this exact subject. Ultimately, the way that you have to think about that density is that a mammogram is an X-ray. And so dense structures show up as white. Your fat in your breast shows up as dark. And what the radiologists are looking for are things that are white. So they're looking for calcium. They're looking for an asymmetry, which is a white area of the breast. They're looking for a mass, which shows up as white. So when you have density in your breast, the radiologists, unfortunately, are tasked for looking for a snowman in a snowstorm. So herein lies the rub. If you're more dense, you're more apt to be called back for additional imaging where you're going to have that adjunct ultrasound. They may be able to rely on the 3D technology from your mammogram done here at Women's Hospital and say, oh, that is stacked breast tissue. Or they may need you to come back and do what's called a diagnostic mammogram, where they put a smaller paddle and they focus in on that area and they push. And like a stack of pancakes, they're hoping that that breast tissue will thin out and go away and they won't see that white portion anymore. And then they say, okay, great, you're good. I'll see you back next year. But ultimately, it leads to a little bit of muddiness when you're dense. And so if you see that you're heterogeneously or extremely dense on your report, I wouldn't cry if you get called back. I think it's just par for the course.
Is there anything women can do to reduce their risk of breast cancer?
Oh, lots. I mean, when we talk about, I think a lot of attention gets brought up to the genetic predisposition to breast cancer. 5 to 10% of all women have a gene that specifically causes their breast cancer, but that's the minority. So the majority of breast cancers are familial, environmental, and sporadic. And sporadic just means that it was going to happen whether you liked it or not. Environmental is really where that middle ground lies. And so anything that you do that is inflammatory, meaning smoking, alcohol use, Obesity is an inflammatory state in and of itself. So what we do on a daily basis matters. And so when we talk to our high-risk patients, we're counseling them on the importance of staying active, staying mobile, minding what you eat. We say what's good for your heart is good for your breast. So the same inflammatory pathways that cause you to have coronary artery disease are contributing to your risk of breast cancer.
So we said familial history. And when would you say women should consider genetic testing? Is that only if you have family history, or if you feel something, can we get it if we just want to know?
We have genetic counselors here at Women's Hospital. They have, in particular, different criteria for different disease states. So your criteria to be tested for breast is different than thyroid. It's different for ovarian, pancreatic, all of the above. And so if you have a family history, I find that most times our gynecologists are doing a great job at doing screening questionnaires. And so they're going to ask the high value information from your family history. And if you qualify, they're going to offer it to you. That testing is a blood draw or a cheek swab where it's going to send that information off to a lab. It's going to analyze for genes that have particularly high incidence of you developing a specific type of cancer, whether that be breast or other cancers. And the importance of that is going to be to know what can you do proactively. So if you're high risk for a colon cancer, you're going to start your colonoscopies earlier. If you are high risk for breast cancer, you're going to start your mammograms potentially earlier. And so even if you don't have that start family history, if you want to know, there is an out-of-pocket cost where you can have your genetic testing done, and the counselors will work through that with you. But ultimately, the vast majority of people are going to be negative. And I think that as good as we're trying to be at putting out the message that it is an option, I don't want it to be falsely advertised as something that you are likely going to test positive for. The vast majority of patients that get tested are negative.
And are there additional screening tools beyond mammograms for high-risk patients?
Yes. So if you are considered high risk, your options, depending on, your genetics, are going to be more proactive. The way that I describe high risk to my patients is that it's a mathematical probability. So we have what's called a Tyrer-Cuzick score. It is a calculation of what is your estimated lifetime risk of developing breast cancer. And that is a compilation of your age, your height, your weight, your breast density, your gynecological history, and your family history. And some of those things are fluid, some of those things are static. And depending on what your actual risk is, if it is higher, meaning over 20%, then you are more likely than an average risk person to have something. And so with 1 in 8 women having breast cancer, 1 divided by 8 is 12. And so by doing your mammogram once a year, that's for average risk individuals. So if I know that your risk of having breast cancer is 25%, you're being underscreened by 50%, just seeing your OBGYN and doing your mammogram once a year. So where do we compensate with that? So your gynecologist does half of the work. And so typically in our high-risk clinic at Women's Hospital, they're doing the other half. And so by being proactive, we need to screen you up to your actual risk. And that means doing a second clinical breast exam, doing additional images, which can include a supplemental whole breast ultrasound or MRI, which is a different screening modality of your breast that is really only available for patients who have high risk of breast cancer status or a diagnosed breast cancer. And so it is some adjunct to what you're already doing to where you don't shortchange yourself, because we can't one size fit all people. We can't say that I'm going to treat you who has a risk of 30 the same as you who has a risk of 12. Now that we have precision medicine, it just doesn't make sense.
And what does it mean when someone is diagnosed with HER2 positive or triple negative breast cancer? I always hear the negative, positive, and please explain what that means.
So surgery for breast cancer is part of a triad. Depending on your surgery, we absolutely need the assistance of a medical and a radiation oncologist. And the reason being is because, again, we learned from back in prior years that surgery alone does not give you a good outcome. Breast cancer is not a surgical disease in a vacuum. It needs a medical component. So I tell my patients to split their thought process into two. We have to treat what's physically there, and the tools for that are surgery and radiation. But we also have to treat for what can be somewhere else. So as much as I like to think that I'm important in the process of treating breast cancer, my job as a surgeon to remove the tumor affects, yes, I stage you. Yes, I can remove your breast cancer, but I do not impact whether or not it will in the future go to your brains, your bone, your liver, any of those things. And so when I talk to patients, I oftentimes ask them, what's the first thing you thought of when we had our conversation about your diagnosis? And they say, the first thing that came to mind is this real? Am I actually hearing the words coming out of your mouth that I have breast cancer? And the second thing that comes into their head is this curable? Is this somewhere else? And so what I do does not impact that. The medical portion does. And so those factors that you talked about are tools that a medical oncologist has to reduce the risk that it not only comes back in your breast, but anywhere else in your body. So the estrogen, progesterone, and HER2 are all things that are feeding this tumor. And they each have their surrogate medical recommendations that focus in on that process to lower your risk that it doesn't come back in your breast or anywhere else in your body. So those tumors that are driven by your estrogen and your progesterone, luckily, there are anti-estrogen therapies, pills, that can be given to reduce your risk. The HER2-driven tumors, there's an antibody that in conjunction with chemotherapy is very effective at treating those tumors. But when you talk about triple negative, what that means is that it's negative for estrogen, negative for progesterone, and negative for HER2. So when a medical oncologist cannot use that pill and they cannot use that antibody, the only tool left in the toolbox is chemotherapy.
Do you stage it like 0 through 4, those specific hormone versus triple negative?
Well, so it's so interesting you say that. In between 2010 and 2018, they changed the way that we stage breast cancer to put more of an emphasis on those factors rather than size and nodal status. So for example, you can have a 3 centimeter hormone-driven HER2 negative tumor in your breast with no lymph node, and you're a stage 2, but you only need to be over a centimeter triple negative only in the breast in order to be a stage 2. There's more of an emphasis of the biology rather than the size and the nodal status. And so that's why surgery still, I think, luckily for my own self-preservation, will still be a part of the treatment of breast cancer, but understanding and eventually biohacking how these tumors work is the future.
And when you find the cancer cells in your lymph nodes, which I believe you said was pretty rare?
Yes, so that is the goal, is that we get to everybody before it's in your lymph nodes. Unfortunately, I still do have patients where the tumor is in their lymph nodes. That in and of itself is a staging portion of it. So when we remove the breast cancer from the breast, that's the treatment. The surgical portion of me sampling the lymph nodes is for staging, and that is typically to give the medical oncologist more information to give you the best recommendation. And so if it already pre-exists in the lymph nodes by the time you get diagnosed, then it becomes a treatment portion. But, hopefully we're getting to the state where most people get diagnosed at a smaller stage, and that will become less and less of an onus on us to have to do our axillary or armpit lymph node surgeries for treatment.
What are common misconceptions about who are at risk for breast cancer?
Oh, I think the low-hanging fruit there is that if you don't have any history of it in your family, that it's not going to happen to you. You know, understanding that you're in the majority if that scenario plays out.
Have you seen more prevalence in women that are like, I don't understand, I'm the first in my family, there's no history?
I think about that a lot, and this is just a personal perspective, but I have two friends currently. They did grow up with my husband, and they had mothers who died of breast cancer when they were 30. And I think that the difference between then and now, because I'm in my 40s, and the medicine that was, treated at that time is very different than where we are current state. I think that we have more technology and we have more access than we had in prior years. And so I oftentimes in the middle of the night think to myself, if we rewound time and I was born now, their mothers would still be alive. And I think that we just did not do as good of a job at identifying and treating younger individuals back then. And I don't think that that's the world we live in. So I oftentimes will talk with my partners about how we do see more individuals who are younger with the diagnosis, and initial knee-jerk reaction, because common things are common, is saying, oh no, more people who are younger are having more breast cancers. I don't think that's true. I think we're just seeing them when we did not see them before.
And oftentimes they probably didn't go to the doctor until something was wrong, or they felt something. With that, how can women be proactive about their breast health? Are self-exams still recommended?
Oh, absolutely. I think that the shift for self-breast awareness wasn't that we don't think that you should do a breast exam anymore. I think that there was a lot of hyper-focus on the breast exam to where patients were stressed when they couldn't quite figure out what is normal or abnormal. And luckily, the imaging is really the onus now, rather than saying it's your duty to figure this out. Again, the dream is that nobody ever feels their cancer anymore. Your mammogram finds it, because that means we're doing our job as a healthcare system. And so when it gets to the point where you feel little subtle things, that's the goal. You want to be able to look in the mirror and say, that doesn't quite look right. And potentially you've saved yourself. You want to feel even just pain, irregularity. One breast looks slightly bigger than the other. And you go reach out to your primary care doctor.
I thought everybody had that.
I know. But what was what out of your normal?
Okay.
But you reaching out and saying, like, I need a second set of eyes on this is completely appropriate, and that's what we expect in medicine. And so making sure that you understand that everything that we do on a daily basis matters, that not having a family history of breast cancer is not a get-out-of-jail-free card. Understanding that the cigarette you pick up and smoke matters. The amount of alcohol we drink matters. Whether we get up and are active absolutely matters. And in the grand scheme of things, sometimes you can't control it and it's going to happen anyway. I have marathon runners who have breast cancer. So you can't beat yourself up. You just live your life the best you can. You go to the doctor, you take care of yourself, and you make yourself a priority. And that's all you can do.
And how can women further advocate for themselves and ensure their voice is heard with their cancer care?
I think asking the questions, having no fear in saying, I didn't quite understand that. Can you please explain it to me again? And finding the best way that you can communicate, whether that's directly with your physician. If you want to go through your nurse navigator, that's also appropriate. That's what they're trained in. If you want to look for a breast community and survivorship and eventually take those questions back to your physician, that's appropriate. However you want that to look, just don't sit back and don't ask the question, because surgery, unfortunately, is irreversible. And these medical therapies and radiation therapies do change your body. And you want to have 100% certainty that that's your journey and that's what you're going to be okay with.
What should women do if they feel something abnormal, but their screening comes back normal?
That is a tricky question. So we do get a lot of second opinions in our high-risk clinic. So our nurse practitioners will see patients with this exact scenario. And a lot of that is because sometimes the clinical exam and the radiologic imaging do not match up, and you need that middle person, a clinician, to clarify whether or not it is dense breast tissue, if there's something actually there and the imaging is, not capturing that portion of the breast. And so we frequently will get referrals for second opinion after normal imaging. And so you can oftentimes ask for a referral to see a high-risk clinic, and that will clarify that. Or if you have an apt, GYN, they will absolutely do that for you as well.
And what would you tell a patient who is scared to get their mammogram?
I would say I'd be more scared of getting a diagnosis that isn't caught. I know there's a lot of controversy currently online. There's a lot of misinformation where patients have this misconception that the radiation from the mammogram is going to cause cancer rather than save their lives. Interestingly enough, I had to do my recertification for some of my mammogram-guided biopsies. And so the updated literature, which I tell my patients, and I love to talk to Dr. Norman about this too, and Dr. Murphy, who are a radiologist. So one 3D mammogram radiation is the equivalent of one transatlantic flight. Also the equivalent of 40 tablespoons of peanut butter. Also the equivalent of 500 bananas.
That's bananas.
So if you're not going to discriminate against all those things, you shouldn't discriminate against your mammogram.
Thank you, Dr. Fauveau, for helping us better understand the different types of breast cancer and the factors that can impact a woman's risk. Conversations like this give women the knowledge they need to stay informed and proactive when it comes to their health. Knowing your body, staying up to date on screenings, and speaking up when something doesn't feel right can make all the difference. Thank you for joining us, and we'll see you next time on UNprivate Parts.
Thanks for joining us for this episode of UNprivate Parts. Don't forget to subscribe to our podcast so you never miss an episode. For more women's health tips and cancer-related content, follow Women's Hospital on Facebook and Instagram. If something you heard resonated with you, please share it with others. Thank you for listening.